Hello, hello.
Hello, sir. Good morning, sir.
Good morning. Good morning. How are you, everybody? Fine.
Yes, sir. So,
That's
July
good.
kosto, sir?
Ekdam Rawat sir. We are missing you people a lot. Okay?
हजुर
Not this thing. You are here studying in the home. पढिरहेको छौ तिमीहरू
हजुर सर अब त एक्जाम नै आउँछ अरे
त्यो फर्मेटी सर्मेट के गर्ने भनेको छ उसले गर्ने भनेको छ के अरे भन्छ नेटबाटै गर्ने भनेको छ ओके सबैले म्युट गरौँ है त म आई विल स्टार्ट द क्लास इज पेरिटोनाइटिस this is not a diagnosis, but it is just a what you call a sign. Right? A group of signs and symptoms that helps the diagnosis of peritonitis. So peritonitis basically is a problem, but not the diagnosis. Okay. If you have diagnosed peritonitis, then you have to add the cause of peritonitis. Suppose it appendicular perforations or GI perforations or gastric perforations or gallbladder perforation or trauma or infection or idiopathic. So peritonitis is a incomplete diagnosis, but it might be just a symptom of any disease that takes place in the abdominal cavity. Okay, that's why this peritonitis means. So before that, you must understand what is peritoneal cavity. Okay, if you see, peritoneum abdominal cavity divided in so many ways. Uh, if you see the peritoneum, this is a parietal peritoneum. This is your parietal peritoneum covering the just inside the abdominal wall. Okay, it goes like this, covers the bladder and uterus, then covers the rectum and goes back and makes the mesenteries, okay, and goes back and covers, and it becomes a visceral one. This one is a parietal peritoneum, this is a visceral one. Visceral peritoneum, parietal peritoneum is very painful, and visceral peritoneum is not painful because of null supply. And the space between this parietal and visceral peritoneum is a peritoneal cavity. Okay, and posterior to the peritoneal cavity, this posterior visceral parietal peritoneum, that is retroperitoneum here. These are all retroperitoneal structures. Okay, so and this cavity is a single cavity connected to each other by one way or other means. Though there are a lot of septums, but they are cavities. The single cavity, the peritoneal cavity is what you call formed by the parietal and visceral peritoneum. Okay, and if you see this parietal peritoneum, there are a lot of recesses or a lot of sub cavities also there because of the structure of the peritoneum and the momentum or organs. They are having different pockets. Like you can see retrovaginal, or pre-rectum, or retrovesical. You see, and this was a hepatic. This is subhepatic. Okay, or this might be your suprahepatic. So there are a lot of cavities inside the one single big cavity of the peritoneum. Okay, and this parietal, this especially the parietes, the peritoneum, visceral or parietal, they are highly vascular, and the function of this peritoneum is one, it secretes fluid which lubricates the intestine as well as the solid organs, and at the same time, it has a such a huge lymphatic plexus in the parietes that it absorbs the fluid from the peritoneal cavity. So it has got both secreting as well as absorbing capacity due to the highly vascular or lymphatic plexus. And on top of that, these secretions, they makes the movement of the intestine or organs, facilitates movement, and there is no adhesion at all. So it prevents adhesion or adhesions between the two organs of the abdominal cavity. So it has got secreting, absorbing as a lubricating factor, which prevents the adhesion within themselves. Uh, as I told you, the parietal lining is inner surface of abdominal wall, diaphragm or pelvis, easily stripped off, separate. It can be stripped off very easily, but and they are all supply the somatic nerve, so they are painful sensation. Whereas the visceral lining, outer surface abdominal viscera, firmly adherent. Okay? There is serosal layer of the intestine, and they can be stripped out, and they are innervating autonomic nervous system, so that's very painful. So, sorry, they are not painful. Whereas the parietal peritoneum is very painful, and the autonomic nerve supply, the visceral peritoneum are not painful. Okay. If you see the cavities, as I told you, uh, usually the parietal cavity, they contains 100 ml of straw color fluid is secreted by the parietal cavity, peritoneal layer, parietal peritoneum. And as I told you, secreted and absorbed by the mesothelial cells through the subperitoneal lymphatic plexus into systemic circulations. And the function is what we call the lubricating. So as I showed you that this is what is a peritoneum, peritoneal cavity, and these are all this kidney and all the structures. These are retroperitoneal structures. Okay, so retroperitoneal space is that. Okay, and all these organs, see, especially the intestines, they are intraperitoneal organ. Okay, that's all. And this is hanged by the fold of peritoneum, that is not mesentery, containing all the vessels, lymphatics, nerves, and they make it two layers, and they form the mesentery. So how the mesentery form? It's a part of the parietal peritoneum, which fold up and make a mesentery. And these are becoming intraperitoneal organs. Okay? That's why they are supplied by the blood vessels, which is running in the mesentery. Okay. Now, if you see more in this place, as I told you, there are so many what you call spaces inside the peritoneal cavity, even. Okay. Uh, and these structures, if you see, all structures are retroperitoneal structures. Aortas, kidneys, spleen, even spleen, you see, this fold of this retroperitoneal. Even stomach, if you open the parietal peritoneum, they become retroperitoneal structure. But because of that, there are a lot of space formed. Like this space is very common, is a lesser sac, you see. This is known as largest greater sac, and here lesser sac. And these are not all splenic spaces. This might be this parietal spaces. Okay, so you can see there are so many spaces in the peritoneal cavity where the fluid get trapped and they don't drain out. Otherwise, normally, if there is no adhesion, nothing left, then what happens? You will have a good flow of the peritoneal fluid inside all spaces. Okay. Now, if you see now in the peritoneal cavity, there are a lot of spaces divided or differentiated spaces by ligament or mesentery. The two compartments above the transverse colon is supracholic, below the transverse colon is infracholic. There are 9 spaces: right and left subphrenic below the diaphragm, subhepatic below the liver, lesser sac posterior to the stomach, supramesenteric, inframesenteric because of the mesenteric attachment, right and left paracolic gutter between the abdomen and the colon, pelvic. You can see the pelvic, a lot of spaces. And there are a lot of other spaces like coronary, gastrophrenic, hepatoduodenal, falciform, and all these ligaments, they make all these spaces separate from each other. And if the spaces opening get adherent, then there will be loculated sort of collection in the peritoneal cavity. Otherwise, if they're not adhesions, they are freely mobile, freely movement of the fluid inside the peritoneal cavity. So any infected fluid, it is it is in the peritoneal cavity in generalized, then there will be generalized peritonitis. If any fluid loculated or entrapped in one of the space, then they is in that space only in painful. Then become a local peritonitis. Okay, they might develop local peritonitis. So that's what it the pathophysiology how they are divided by anatomical factor. Uh, the same picture in different way. You see, you can see this is below the diaphragm. So this is known as right subdiaphragmatic space because it's the left side. The one is in the left side, left sub diaphragmatic, and these are all subhepatic space. Okay, and they have got this is paracolic glottal, infrahepatic. This is paracolic glottal. This is a Morrison pouch, and they have got a connection with the suprahepatic. They have got good connections, like behind the stomach, or gastrosplenic ligament. This is they make a space there. So splenorenal recess, they make a space there. So they have got a good connection, as I told you. But once they get adherent, then this get one single pocket. Or once there is adherent of subdiaphragmatic space, they become loculated. Then they will have their own pathology presentation than the general peritonitis. Okay, so these spaces externally it can't be differentiated or can't be anatomically located, but once you open, then you have to open all these spaces if there is what we call peritonitis or local peritonitis. If you see the physiological wise, peritoneum, if you spread it, take it and spread it, it's quite a big issue, almost 2 meters square, equal to the skin area. Okay, if you just have, so you can imagine if you express this peritoneal layer, how big is that? So it would be having a good what you call bidirectional transfer of the substance like fluid and electrolytes, and particularly absorption through the subperitoneal lymphatic flexes. Okay, a mesothelial layer facilitates rapid sealing following injury in the matter of hours. So these layers they seal the perforation or injury are the type to localize the foreign body inside the peritoneal cavity, and this fluid prevents tissue adhesion because of the smooth surfaces. And they have got the property of inflammatory and immune responses. And they have got the property of fibrinolytic activities. So that this physiologically, the peritoneal cavity, the peritoneal layer has got different preventive as well as normal physiology maintenance activities in the peritoneal cavity. So what is peritonitis? Simple, inflammation of parietal or serosal visceral layer of peritoneum. That's just inflammation of parietal, the parietal or visceral peritoneum. That's peritonitis. Okay? Now, how to classify peritonitis? Or in other way around, this may be the causes of peritonitis. According to the organism, it's bacterial or it's non-bacterial. Okay? Or according to the space, it's localized, diffuse, or generalized, as I told you before. According to etiology, it might be primary, if you know the cause. It's secondary because of some other cause. Tertiary, it's infection from other places that comes and cause that inflammation in the peritoneum. That's a tertiary. Okay, and if you see the etiologically factor, it's an invasion of peritoneal cavity by a bacteria, spill of fluid from the viscous perforations directed to the peritoneal attachment. Okay, that's one. That means if there is any bacteria or perforation that spills the bacteria from duodenum, appendix, colon, diverticulitis, jejunum, gastric, Meckel's diabetic bladder, gallbladder, fallopian tube, from any place. If they get rupture or perforation or they migrate, translocate the bacteria in the peritoneum, they might cause the peritonitis. So, inside the abdomen cavity, there are so many hollow organs. Due to any cause, if there is a leakage of um, uh, content of that hollow viscous, which has got very high bacterial load, they might cause peritonitis. This is a Valentino syndromes known as this is a bacteria that spreads out from the viscous causing the what you call the peritoneum. So if you see in the X-ray, what you see, this is a normal chest X-ray, but this is a diaphragm and this is a diaphragm. You can see a gas shadow. This is a place for a liver. Okay, this is a place for a liver. This is a place for a stomach. But you can see the gas, free gas between the diaphragm and the liver. That means they have free gas. Usually, normally, we don't have any free gas between these two layers. Okay, but there is gas. From where it comes? So definitely, it has to come from the perforation of the hollow viscous, or somebody has pushed a knife and air might have gone from outside. Okay, like laparoscopy, when you push the air to inflate the abdominal cavity, the air is entrapped there in the subdiaphragm, and you can see the gas shadow there. So, gas on the diaphragm means it has come from the probably it has come from the hollow viscous rupture, proof otherwise, and causing the infection of peritoneal cavity. And once the peritonitis develops, what happens? You see, the intestine they get dilated. They make the plexus, mesenteric or arterial plexus, they get paralyzed and they get distended. So this is paralyzed. So this is not a paralytic ileus. Okay, the intestine got paralyzed, so they get distended. So that's how we diagnose in plain X-ray. You see what we call gastrointestinal diaphragm or distended or paralytic ileus, or this picture is ground glass appearance might be a feature of peritonitis also. Okay, this might be a feature of peritonitis when you do X-ray of the abdomen cavity. So these are the typical feature of the peritonitis. So if you see the etiologically, I told you that bacterial and non-bacterial. So non-bacterial might be if there is pancreatitis or mucoperitoneum or rupture of the bladder, or might be the bile leak. So in those cases, what happens? They get irritate and they might cause inflammations, causing what you call the peritonitis. Penetrating injury, bullet, stab, or roadside accidents. If any foreign body goes inside, they might cause also inflammation of the peritoneal cavity and cause peritonitis. Surgery. Once you open surgery or laparoscopy, whatever you do, there might be infection might go inside and might cause peritonitis. Or when you put a drain, so through the drain, the bacteria might migrate into the peritoneal cavity and cause peritonitis. Or when you do dialysis, or when you do aspirate what you call the tapping in the ascites, that might cause also peritonitis because you have introduced bacteria inside the peritoneal cavity. If you have general bacteremia, just suppose there is what you call urosepsis, okay, or glomerulonephritis, common cold, or tonsillitis. In those cases, what happens if it is salpingitis? So in those cases, what happens? The bacteria in some other places might be taken by the blood supply, blood vessels, and they might cause inflammation of the peritoneum. So either there could be bacteremia in the initial stage, and if it is not well take care, they might develop septicemia. And in those cases also you'll develop peritonitis. Or sometimes, translocation organism from the gut or intestines, but the seepaging of this organism from the bowel might cause also what we call the peritonitis, a transmural spread of the disease. Okay, I told you there might be other classification, chemical cause of peritonitis, like bile, blood, sometimes barium might get leak, or urine might get leak, or when you do sometimes histosalpingogram, the dye might come out from the fallopian tube and cause irritation of the perineum, that might cause peritonitis. This is what we call chemical peritonitis. And allergic peritonitis also sometimes in the olden days when you used for the surgery the multiple use of what you call gloves. They used to put the stars during that time to make it easy to wear on. So that might cause also allergic peritonitis. Trauma, as I told you, due to surgery or any procedure, or might be stab or whatever it is, or road traffic accident, the foreign body might go inside and cause what you call the traumatic peritonitis. Sometimes the arterial occlusion, embolism takes place, or thrombosis takes place. If the intestine get strangulated, or there is intestinal obstructions, in those cases also, or by mesenteric vessel obstructions, so in those cases they get ischemic changes. So that might cause also peritonitis. And other cause like familial Mediterranean fever, that is a miscellaneous type of peritonitis. There might be many causes of peritonitis you might come across in your day-to-day practice as well as in your physical paper also. So how this happens? Okay. So the infection takes place once there is a viscous perforation either from duodenum or appendix, ileum, colon, or diverticulum, like from typhoid perforation from the ileum, terminal ileum, colon, carcinoma, or when you diverticulum, Meckel's diverticulum, or diverticuli. In those cases, when they get perforated, you develop what you call the bacteria comes out and infect the peritoneum, cause the inflammation and cause peritonitis. Transmural translocation means like organ is somewhere, like pancreas, cholecystitis, ischemic bowel. So the secretion, that toxic matter, they fall down and they might cause what we call the peritonitis. Exogenous contents like drain, open surgery, trauma, or dialysis. So this is how the infection go from outside in and cause peritonitis. As I showed, in peritoneum in female patients, pelvic inflammatory disease, ectopic pregnancy, histosalpingogram, as I told you before, they might cause peritonitis. Or hematological, as I already told you, bacteremia, septicemia might cause. Basically, it's a very peritoneal cavity is a sterile cavity having only 100 ml of fluid secreted by the peritoneum layer, and they circulate, get absorbed, so they are quite sterile. But if the bacteria that is translocated or that seeps from the intestine might cause what you call the peritonitis. If you see the bacteria in the proximal intestine, they are less in number. The more you go more distally in the terminal ileum and colon, they have got a high number of bacteria. The more you go distally, you will have a high number of bacteria. Okay, and these bacteria, they grow and they get more media when there is distal obstruction in the intestine. Okay, and there will be less motility of the intestine because of different reasons. So this on that media, the bacteria grow very fast, and the number of bacteria is very high. So any perforation in that distal one, they have got more virulence of bacteria than proximal one. Okay, so that's why these conditions where the intestinal bacteria comes out as a in perforation or translocation might cause severe peritonitis. So the bacterial organism, they're mostly gram negative, and they have got the endotoxin in their cell wall. They release humononuclear factor, interleukin 6 from the leukocytes, produce endotoxins, and they develop shock. And endotoxin, when they come in the circulation, they develop shock, decreased blood pressure, impaired tissue perfusion, and tachycardia, dehydrations, and a lot of other organ involved in the by the endotoxins released by the cell wall of the uh, bacteria. And bacteria causing peritonitis, they're commonly E. coli, aerobic or anaerobic both type, Streptococci or Streptococcus faecalis, Bacteroides, Klebsiella, Clostridium, we'll say, all from GI tract. And from non-GI tract, like from the chest wall or from the general organs, pneumococci or gonococcus, they come and cause the peritonitis. So non-GI pathogenesis are infection from the pelvis, like fallopian tube, chlamydia, species of gonococci, transpiratory spheroorganism from the perihepatitis, or tuberculosis, pneumococci, streptococcus, or some fungal infection might be there, which might cause peritonitis. Okay? So these are all the factors that cause peritonitis. Once the infection sets in by means, any means, by trauma or by bacteremia or by perforations or injury or surgery, whatever it is. So a lot of fluids that secreted within the bacteria and toxins leading to bacteremia, toxemia, and septicemia. Okay. These bacteria cause just overload of bacteria in the blood, and they develop to secrete all the toxin material from the cell wall, and that might cause more damage to the tissue or the organ, and they develop septicemia. Then, once the body can combat this bacterial action of any organism, if they have got good immune system, if they have got good protective system, then they will lead to healing process. That is, when the heal takes place, the fibrinogen from the fibrin, they deposit and they localize the infection source. Rather, it will prevent to diffuse and go to systemic infection. So once all the toxins are combated by this body, by immune system, they try to localize the infection and develop local peritonitis. What happens? The thick flakes are formed adherent to the bowel. Once the defense mechanism overpowered, there is fibrin deposition. That's a good sign of healing. So it covers whole the intestine below the level of the parietal peritoneum. And this peritoneum get thickened, edematous, and the valvated radius and loss of glacial surface and adherent to localize the site of lesion. So this fibrin is deposited above the intestinal organ, above the parietal peritoneums or vesical peritoneum. They are very thick. So it is very easy to separate those thickened peritoneal fibrin flakes initially. Once they get healed properly, or all the bacteria that are gone and immune system has overpowered all these bacteria, then they become very thick and they become a cocoon. They will cover whole intestine inside a small thick packet of the fibrin layers. Okay. And sometimes if there is collection inside this, between the loops of the intestine or in the spaces, okay, they might come as a bowel loops, and they form the pus formation in local pus formation, or if they spread all over, they might cause the generalized pus formation within the loops of or distended intestinal loops. So, though there is a defense mechanism, good immune system, good protective mechanism, there is a thick layer of fibrin. They form as a result of the healing process. But there are some places in between the loops of intestine or in the local spaces, there might pus collection takes place, and they might be staying for a long time, and they may come out or they may present themselves once the body resistance or weakness takes place. Okay. So severity of the peritonitis depends upon the bacterial load. See, so if it is very high load, 2 into 10 power 8, okay, then there will be severe severe peritonitis. And the peritonitis severity depends upon the virulence of the organism, how virulent. And as I told you, host immune defense level. If it's a good immune system in the host or the patient, they will overcome, you know, and how much the blood can phagocytes or neutrophils activities active, they might overcome to the infections. And if this mechanism or immune mechanism or phagocytic mechanism or blood count and or comorbidity are there, this very anemic patient, nutrition very poor patient, okay, then what happens? The body can't control or prevent or take over the bacterial toxicity of because of virulence and the bacterial load. Then what happens? These bacteria, they start multiplying. They multiplying so much and they start secreting a lot of toxins, developing toxemia. And there is a what you call there is a failure of defense mechanism, so cause is formed. And after that, the septicemia, the local infection might cause systemic involvement and develop a septicemia, causing what you call organ failure, the multiple organ failure. Okay, so sometimes usually the speed of leakage means if when there is a perforation in the GI tract, if there is a very forceful perforation and it can eject high amount of what you call uh, leakage or content of the intestine, the chances of getting severe peritonitis is very high. So depending on the speed of leakage, also important in um, in severity of peritonitis. Local peritonitis means severe peritonitis means there is pain all over the abdomen. Might be even thoracic abdomen or pelvic abdomen or general abdomen. But if there is local one in only one compartment or one between the only one loop of the intestine, so they are known as local peritonitis. Okay? Like in any compartment or gutter or space. Okay? The only fiber depression and the peritonium is thickened and omentum also adherent in that part of the local places, and there is restricted peristalsis. So this all happens in one small portion of peritoneal cavity. Okay, that's what it happens. And to prevent them, the intestinal organ itself protect, not let the infection spread in the whole abdomen. Okay, so they try to localize the infection in particular gutter or space or compartment in abdominal cavity. So then they develop the local peritonitis. And if the peritonitis is generalized peritonitis, the prognosis is not that good. But if it is local peritonitis, actually the 20% of the local peritonitis, they get resolved by itself. Don't need to do any surgical intervention or very high antibiotics and other supplement therapy. But if it is not just local but a systemic one, then you have to go for quite a extensive and early management of the peritonitis. And if the infection is, as I told you, spread all over the abdominal cavity, okay, or if you can't control the peritonism, the peritonitis locally, peritonitis in time, they might go for general peritonitis. Like suppose there is appendicitis. Usually that is a local peritonitis that develops first. But if you can't control it, and if there is let that what we call the infection of appendicitis spread, what will happen? There will be extensive peritonitis and general peritonitis. So what is the factor favoring for general peritonitis? Spreading of peritoneal contaminants, contaminants rapidly, okay? Very rapidly spread. Then spread is always, uh, exaggerated by the movement of intestine. That's why when there is pain in abdomen, we let not patient to eat so that the intestine doesn't move. If you eat, the intestine moves, and there might the factor which will give a good spread of the peritonism. That's why we ask not to eat anything, keep quiet, keep rest. Or again, the virulence of infectious organism. how virulent the organisms are. And if the stimulation of peristalsis, as I told you, hinders the localization, so oral food or purgatives or enema, they might cause more stimulation of peristalsis in the intestine, and they might cause the diffuse peritonitis, which is already localized. And if the omentum are not well developed, because omentum are known as the policeman of the abdominal cavity, if there is short intestine omentum, like in children, see, they don't reach down of the pelvic cavity or appendix. So the chances of getting general peritonitis is very high in young children. The same thing with the old people. If the omentum in the old people, they are very sluggish. Actually, depending on the blood supply of the omentum, they are very active. Young persons, young people, very good blood supply, they move very fast. And they can cover up, go and protect that area. But in old ages, or in children there is short omentum, in old age there are very sluggish omentum. So they can't protect the inflammation or infection to be spread out. Okay, if the pus that is in the localizedly situated, like in appendicitis, perforated appendicitis, they're localized first. But the pus disperse, or when you palpate or might during movement, they might spread out and causing general peritonitis. Or probably if there's some patient have got comorbidity like diabetes or hypertension or drug-dependent steroids, having AIDS, old age. In those patients, immunocompromised patients, what happens? The spread of peritonitis leading to general peritonitis. And 10% of general peritonitis, if you don't treat properly, they might die. So clinically now very easy. In general, they will have severe, sudden, or gradual pain at the site of disease, depending on the cause. We have seen so many causes of peritonitis. So they, because of pain and inflammations and fever, they will have nausea, vomiting, fever. Then because of septicemia or bacteria, they will have feature of shocks. And when you palpate, when you see them, you see the hypotension, tachycardia, feeble pulse, tachypnea, and shocks feature. Definitely there will be dehydration. Because of dehydration, there will be oliguria. Because of paralysis, they will paralytically, they will distend the abdomen. They might localize or generalize the tenderness. The moment you touch it, they will tender because of the inflammation of parietal peritoneum. Touches the inflammation of the visceral peritoneum. When touches it, the parietal peritoneum, they become very severe tender. So when you touch them, you palpate them, they will have hold their breath and tighten the abdominal wall. So that's what you see in the peritonitis. And if you listen, there will be bowel sound is sluggish or absent, and there is always guarding of. They will not want to get pain, so they will guard their abdominal muscles. So they make it rigid abdomen. Okay, there are so many other parameters where you diagnose peritonitis, Apache-2 classifications, or Moniam's peritoneal index, where there are 8 parameters. You just go through. And don't forget to, for example, rectal examinations. If there is peritonitis, generalized peritonitis, when you do PR, they will have very painful pelvic region, the peritoneum. When you touch the peritoneum or rectum, they will have severe painful, tender PR. In the contrary, the visual inflammation of one zone or one content is localized. There might be general symptoms or nausea, vomiting, or fever, or tenderness, or feature of mild shocks, then depending on the site. Or all that sign will be of localized one, tenderness, deep tenderness, local guarding, okay, rebound tenderness. When you press it and leave it, they will have pain. There might be guarding or rigidity. When you do a PR, and if you see in that area, right iliac fossa, or suprapelvic or retropelvic area, there might be painful when there is pelvic inflammations. Okay, so localized means they are in the one particular part of the abdomen. The line is whole abdomen cavity. Now, diffuse peritonitis, inflammation all over the abdomen. Okay, early what happens? There is severe pain at the site of lesion, and they might spread all over. There is a feature of inflammation, so there is infection, signs, symptoms of infections. The systemic symptoms like slow bowel sound and absent later on. That is, If there is paralytic ileus, there will be sometimes vigorous bowel sound in the initial stage. But once the inflammation goes on or continue and gets severity, the bowel sounds absence. So intermediate stage, if the localized patient gets better, otherwise it gets generalized. So if you can control the patient when there is a localized peritonitis, that's fair enough. The patient get well. But if you can't control the localized peritonitis, and once you get generalized, then it becomes quite difficult. So it spreads all over the abdominal cavity. So you will find tenderness all over the abdomen and rebound tenderness, rigidity and guarding, and there might be absent of bowel sound, abdomen is distended, and when you percuss, there are tympanic notes in the abdominal cavity. Once the stage intermediate stage also passes and you can control the inflammations or infections and give a good supportive treatment, then what happens? The peritonitis will diffuse. In those cases, then general features of shock and Hippocratic face, you can see this lady's face, how does it look? Okay, this is not a Hippocratic face. There is calm, cold, clammy skin, there is dehydration, sunken eyes, dry tongue, and dry skin because of dehydration. There will be fever pulse, tachycardia, hypotensions. If there will be fever, if there is early stage, there will be fever, there may not be stage. Tachypnea, shallow respiration, irregular respiration. There will decrease output, and even they might be unconscious. That's late stage of the peritonitis. So you have to do basic CBC count or CRP, C-reactive protein, liver function test, blood sugar, serum lipase, amylase, blood culture, or RFT. Okay, blood group and cross matching. You will have a different parameter of findings. Patient for routine urine and culture, they have a X-ray, or we can go for ultrasound, just X-ray, CT scan, enhanced CT scans, MRI to find out what is the cause of the peritonitis. Investigation-wise, it's very important parameter you have to do. Once you want to see you don't have anything else like even blood count or X-rays, ultrasounds, MRI. Then what to do? This you can see. You can just do a parasynthesis. Just pass a needle in the peritoneal cavity, okay, and see the tapping and the peritoneal fluid that you aspirate. If you send for for biochemical estimation, the initial pH is quite high. The sugar is less than 5 grams per deciliter. There is raised peritoneum protein and LH is raised, and there is good blood count, WBC counts. That means there is an indication of peritonitis because of some cause. Okay, then you can send the same thing, the aspirate fluid for gram staining, culture and sensitivity, and even you can do amylase and bilirubin and creatine for that. So that will give some idea of how severe is the peritonitis. You see, there are a lot of diagnostic laparoscopic tests you can do. You can see directly the inflamed appendix, or there are some perforations in the gut, and there is collection, inflamed gallbladder. Okay, so these are the few pictures I've just shown you, but there are a lot of pictures you can get it once you know the cause of peritonitis. There are different diagnoses of pancreatitis. There's a local sort of peritonitis, intestinal obstruction, drops of acute pregnancy, acute pyelonephritis, acute mesenteric ischemia, diabetic abdomen, and so other causes also you have to differential diagnosis. If you don't treat properly, they might go on paralytic ileus, abdominal abscess, portal pyemia, errogen mass formation, intestinal obstruction, and superficial surgical infections, poor wound healing, suffering abscesses, fistulas, external or internal, abdominal compartment syndrome, because once you don't treat properly, this intestine, they get severely distended and their collection, so pressure of the abdomen will increase, that is known as abdominal compartment syndrome, and there might be weakness of abdominal walls because of the incisional hernia, and sometimes because of non-wound healing, it might burst up and known as burst abdomen. Systemic complication of surgical infections, septicemia, renal failure, ARDS, DIC, multi-organ failure, and mortality. Because of this all are because of septicemia, severe septicemia. The treatment principle are just research the patient. ABCD, don't forget the ABCD, research the patient. Control of infections. Okay, you control infections and give supportive treatment, analgesic and nutritions. Okay, antibiotics. And once you research the patient is fit, go for further treatment, then you go for definitive treatment, general treatment, specific. If you know the cause, what is the cause, then you just hit that cause and treat specifically. Then you have to have a very good course of care. Patient has to be monitored very well, and good follow-up will send back the patient to the society. Okay, so these are the basic principle of what is peritonitis. You have to understand. Now, when you taught a specific disease process, then they will be talking again about what you call this cause of peritonitis. Okay? Yeah. Sorry. The resuscitation, yeah, A, B, C, D, I told you, airway, oxygen, to just hypoxia, sinuses, tissue, oxygen perforation, breathing, chest, respiration, oxygen exchange, circulation, CBP line, you can put ABG analysis, pulse, BP, hemoglobin, electrolyte, cardiac functions, anemia, nutrition, coagulopathy, IV fluid, blood and blood product, organ function, the kidney, brain, periphery. So most important that once they are localized, you have to see all these things. But once they go in septicemia, you have to see, respiratory functions, kidney function, brain function, then even what you call intestinal function. You have to see. They got affected by the septicemia. That's why resuscitation is very important in those cases. So for the control of infection, you have to use broad spectrum covering gram-negative and gram-positive aerobic and anaerobic organism. Then you take the pus or fluid and send for culture sensitivity, prevent bacterial multiplications, and check endotoxin production organism, and you just treat according to what you call the organism that is isolated. Support treatment, nutrition is very, very important. So you have to give total parenteral nutrition and physiotherapy, chest and musculoskeletal therapy, very important right from day one. You have to prevent DVT, and you have to prevent all that pressure point in the back or heel. You have to take care of the mouth, bowel, and bladder. So you have to put NG tube if needed. You have to pass polyscatter to monitor the urine output. Treatment analgesic, you have to follow the WHO guideline of analysis here pattern. You have to first try to get the simple paracetamol, then we add codeine. And the last, if not, then you can add for morphine these times. And always psychologically, you have to boost the patient, decrease the stress, and good physiotherapy, prevent DVT, pulmonary embolism, and cardiac function, maintain a good cardiac function. Okay? Always keep the patient in ICU. You need a very good monitoring and look after by 24 hours, 7 days. That depends upon the severity of disease. Wait and watch, that's close monitoring. Monitoring every 4 to 6 hours, even every 2 hours also you have to monitor, or you have to stand by the patient if there are very severe cases and assess the improvement. And if not better, then think of surgical interventions. So don't do surgical intervention patients till they are not fit for surgery. And surgical intervention may be very high risk concern, you have to take it. You have to go to open the abdomen and see what is the cause, or you can go laparoscopically, just can see what is the cause, and according to that you can treat. Otherwise, if not that facility, then you have to open the abdomen and identify the cause, the diagnosis, what is the cause of that peritonitis, extend the local diseases, treat the cause. Surgery should be planned and decided there and there. And consultation with anesthetist is very important. And peritoneal lavas, thorough washing of peritoneum. You shouldn't have any pus or any debris or any foreign material inside. You have to wash by at least 6 liters of lukewarm normal saline. Clean it repeatedly, so that till you are not happy, you just clean it and clean it, and close the abdomen. And if you want, you can put a drain. Posture care, you have to take care of the ventilation of oxygen saturation. It should be always 100%. Electrolyte and fluid balance is very important. As I told you, nutrition and blood supply and products. So to make the hemodynamic stability, intake output chart must be maintained, otherwise they will develop pulmonary edema or limb edema. A very good antibiotic should be covered. Don't hesitate to get a good wide broad coverage antibiotic. And always encourage patient for physiotherapy, active or passive, especially chest and limbs. Okay, so that it will prevent ARDS and thrombosis and good what you call activities and prevent bed sore. That's very because they have to stay for a long time in the hospital, so you have to prevent bed sore. Okay, that's all about the peritoneal peritonitis. So in the last, I'll tell you, it's not a disease as such; it's just a symptom of a disease. But you have to find out what is disease inside causing peritonitis. Is that important? Okay, you are all there or left?
Okay, sir. We are here, sir.
That's good. Thank you very much. You go through the books. Belly Love is very